Oh, I'm just wasn't hitting
My magic finger.
the right place. Good morning. We're going to go ahead and get started. We were well aware that two of our members had a conflicting meeting. We're all doing a lot of study committees right now, but I think Pat Gardner, hopefully, Representative Gardner will be joining us before we get too far into the meeting. So it is good to have y'all here. I'm Katie Dempsey, and I have with us here today Rick Jaspers, Representative Jaspers, and Roma here. And y'all all, I know you all know Roma Amin, and please continue to email her with good thoughts and good ideas and things we continue to need to add to the conversation about children's mental health. We're going to start off this morning with our first speaker, Sue Smith from Georgia Parent Support Network. And I believe you have maybe someone else with you too. Is that right? Okay. Would y'all rather sit? Would you like to sit together up here, if either way, or stand, whichever? Maybe. Why don't you come sit? Why don't you just come sit here in front of this microphone? It's a little more comfortable, I think.
When I see this on TV, it's like.
So when this one is that one. So you may have to pull that microphone up kind of close to you just to make sure. And Ms. Sue, how about if y'all take just a minute and introduce yourselves, tell us a little bit about yourself, and then speak to us about Georgia Parent Support Network.
Well, I am Sue Smith, and one of the founders of the Georgia Parent Support Network, and we are 27 years old this year. We have been advocating for children with mental illness, emotional disturbance, and behavioral differences through the years, and we've seen a lot of changes, as have you guys. I brought our brochures, which tell more about what we do and how we do it, and that again too changes depending on what's happening in the state at the time and what's needed. Our work has been varied. One of the things we do is therapeutic foster care with a number of homes. We have a peer center for transition age youth, which is always a challenge. We have a warm line, and we answer about 70 calls a week. And we have parent support partners, which is one of the newer things, peer support for families, which I believe will probably be in the Medicaid array pretty soon. Medicare, sorry. So those are the kinds of things we do. We try to kind of have ourselves in the neighborhoods, talking to the people and working with the people who are really not reaching the service systems and not connecting with the service systems. Okay. and I thought I was hearing voices. Other than that, I'm Danny's mom. When Danny brought me to this work, and I guess quite a few of the people here know Danny or of Danny. She's been kind of front and center in children's mental health and allowing us to advocate, learn by her experiences and advocate for others. So I would be happy to answer any questions. We've seen all the changes you guys have seen, and I did want to say one thing though. In the last meeting, one of your panel actually talked about being an FFA, FHA person, and I think from my own rural Georgia childhood, that was one of the things that actually helped me survive and get through. So I did want to remember to mention that. Any questions you'd like to ask me about Georgia Parent Support Network?
Anyone have any questions regarding the network? And you,
Okay.
Representative Jaspers.
Yes, ma'am. Thank you for being here this morning. Just educate me further. Now, how broad are y'all? I mean, where are you located at? I mean, are you throughout the state? Just metro?
Our office is about 2 to 3 miles from here. We're in Southwest Atlanta. We have 21 chapters as of today that are in most of the state and growing. Obviously, probably most of them are in the Atlanta area, but we do have them in other parts of the state. And I believe just last week, several people in different parts of the state had put in applications for new chapters. So we are becoming statewide.
And so for someone to do that, they would just be a group of people interested in children's mental health, and they would contact y'all to
Absolutely.
create.
We have a person who facilitates, supports. We actually pay the initial fee for the chapters to start. And then today, that's why I'm leaving here as soon as this is over, once a month we meet with all the chapters in our office. And we have a really good attendance of people that come every month to meet and get updates, and Ramona's one of those people that generally comes to the meetings.
What, I keep asking questions.
Please.
I'm a curious guy. So,
She used to do
how do you get your training
services
to be able to effectively counsel people? Is that the appropriate word?
We do not counsel people. We advocate and support. Now, in our work at Georgia Parent, we do have people that counsel, but that is different from our advocacy in chapters.
Okay.
Our chapters are family support for families, much like NAMI or Mental Health America have chapters. We have chapters. Their target would be families of people raising children, parents of people, grandparents of people, foster parents, adoptive parents. And we try to provide assistance, help, and support for them along the way, answer to their needs, provide all kinds of training and information for them.
Okay. How do you get your funding? What's your funding stream? Are you self-supported, or are you? Some of this work we do is self-supported, some is fee-for-service. Particularly our chapter work is supported by a large part by DBHDD. Okay.
But before DBHDD, we still did it. It's just we're able to support more fully and do a lot more work with funding.
Okay. Well, thank you. Thank you, Madam Chairman.
Wonderful. Representative Gardner.
Thank you very much, and thank you for being here, Sue. She happens to be the person who introduced me to Wraparound Milwaukee, which I visited, which provided really wonderful wraparound services for children in Milwaukee. And when I went to visit it, I learned that the model really was developed by Sue Smith. So I didn't know. I'm sorry to have been late, Madam Chairwoman, but I did want you to talk a little bit about your expertise in wraparound services, since that seems to be something that we're thinking about again. I mean, can you do it in 3 minutes? Or
I can
Take the minutes that you need to explain that.
I can tell you that I was lucky. I was in the right place at the right time a great many years ago, before children's mental health became something that we all talk about.
Lucky is
And
the
in
word
my-
you use.
Lots of years ago. In my search for services for Danny, which is a whole story in itself, and lots of miracle and a lot of support along the way, I met the leaders of Wraparound just as Wraparound was getting started, the Carl Dennises and the John Vandenbergs and Beth Stroh and Bob Friedman and, all the people you read about. And by some absolute miracle, they became best friends of mine and still are. So I was on the ground floor of Wraparound. I have worked in 46 states promoting Wraparound, training Wraparound. With a couple of programs that we started here in Georgia, Wraparound Milwaukee sent people to Georgia to our programs 7 times. So we've kind of been in the mix and the forefront of community-based services that are as near to home. And, I want to say cheap. Cheap's not the right word, where we make our dollars go as far as our can, stabilize homes and communities, stabilize situations and families, and then see what we need in order to provide the very best care we can for our children and their families. Because what we've found in these years is that if we do not provide for our families in some way, shape, or form, what we do for our children will not be nearly as meaningful.
Well, it seemed to me that it was a really good model, and I really appreciate the expertise that you have and hope that we will take advantage of it again.
I venture to say, if anybody can remember, at one point we were fortunate enough to have a grant that came through the Fulton County Regional Board under Ernestine Pittman, and we had a service called CHAMPS, which was a total wraparound service funded by Lynn Copeland and Ernestine and their vision. We sat with the leaders of Fulton County for 9 months, and I mean Morehouse, Northside, Grady, Chris Kids, the usual names you will recognize. And we developed what we thought would be the best system of care ever, and Beth Struhl came down and helped us, the writer of the book. And so when it rolled out, a lot of things happened which would take too long to explain, but we became Georgia Parent Support Network, the lead agency of the collaborative, and our job was to get all of the partners to the table. It was an amazing story, an amazing journey. We were funded to serve the 200 most severe children in Fulton County, and that was as identified by the collaborative. The judges, Judge Sammy Jones was one of those people. And at the end of when everything changed, the great children's change, we were serving over 600 children with the same amount of money, using the total wraparound approach.
And they were federal dollars?
DBHDD dollars. They were a mix. Some was block grant, some was federal, some was state, some were fee for services. It became, after we stabilized the service and got all of the partners connected, we were billing Medicare for it. Just Medicare billable.
What year was that you began as the lead agency for the collaborative you were speaking about? Approximate.
That's a hard question.
Approximate. I'm sorry.
Well,
how long ago do you have? Is that
in the neighborhood of 18 or 19 years?
Okay.
20 years
I certainly can give you an exact date, but
No, that's good. That's good. I was just, trying to get a picture on it.
When did it end?
almost everybody in this room can answer that, but me probably. When we went to the fee for service for children, when we changed actually the way services were delivered, is when it ended, because we were a collaborative of providers, and in the wisdom of the federal and state governments at that point, the collaboratives became independent core providers, and we were all competing with each other. So it was a very interesting time. I think many providers went out of business, and some are still in business today and doing well.
Mm-hmm. If I tell you what, let's hear from Mr. Shields, and then we may come back and have a few more questions for you if you'll hang with us a little bit. Tell us a little bit about yourself, please.
Surely. My name is Ramona D. Shield. I am the mom of the young man who's the star, the rock star right there, Curtis. You can't see him, so I have to turn him around.
Okay.
Sorry, y'all got to see him. And so that I could stay calm, I'm going to read a really short poem, and I want to say good morning and thank you all for inviting me. The short poem says, warm thoughts can make the sun a little brighter, the sky a little bluer, and the world a little nicer. So I wanted to share that with you all, to just say that, those are the things that I hold on to, and little poems and little short notes from people who care about me and cared about Curtis that says, perhaps they are not really stars in the sky, but rather openings where our loved ones shine down to let us know they are happy. I said that because Curtis is no longer here with us on the earth. He is in my heart. He's the person that shines in the night. He was a young man who was my son through adoption of my brother, and his dad is no longer here. I am a person who have lived experience of having many family members, including my son, who had mental health challenges. Curtis was raised in Georgia from the age of 8 years old. I have been through multiple wraparound, many systems, hospitalizations, special education. I am very, very seasoned around all of the multiple systems with Curtis. Curtis took his own life death by suicide on April 6, 2014. So it's still relatively new and still a sore spot for me. So I always try to start off on a positive note. I became familiar with Wraparound, all of the wonderful world of education, about 2005 when my mentor, Sherry Valines, who was a very close partner with Sue in this work, and Sherry and had a group of parents who were just mad as HE double hockey sticks and couldn't take it anymore. And so she had a group, and that's how I became involved in 2005. And we came together and became educated through the Georgia Parent Support Network. We were a chapter. We went to conferences. We learned to become more empowered. So bring it more current, I am now the director of that same Family Policy Council in DeKalb County, and I do the same thing. I share support, I educate parents, and I will not be defeated by systems, and I will not be defeated by the fact that my son could not fight anymore. He could not take the transition of being an adult. Because it changes a lot, and there was a lot of gaps in his services. So what I had me a little speech to tell you, so I won't go on and on. The reason that I wanted to come and I was invited, and Sue was happy to select me, was because I feel that there are some significant gaps in our services for children, and I don't know whose plate it needs to get on, but one of the things that we said 20 years ago when my brother passed, in a rural county, and he had mental health challenges, it wasn't there. When I was raising my son in 2025 through 2014, it wasn't there, and it still isn't there. And that gap is male companionship, males who will be there for these young men. My son had providers that didn't look like him. A lot of mixed messages about what kind of medicine he had, about 12 diagnoses. I mean, it's really difficult for parents to feel hopeful in this arena when the professionals really struggle with what is this and how do we fix it and how do we get parents at the table. So, male providers are not available. When I was raising my son, certified peer specialist was not available. But it is, thank goodness now, that they are looking at having support for parents, where parents will actually have a person that will walk the walk with them. I am also a certified peer specialist parent, so I will be supporting parents in my organization as it begins. And I just wanted to bring you to a more current situation that I know of, that right now I work for the state, and I have a coworker who's suffering in silence. She has a 9-year-old son. She works for the state, but she has a low income. Her 9-year-old son is suffering with some severe mental health challenges. She is married. She has everything that people would think would be perfect. But when you're raising a child with a mental health challenge, you need a lot of flexibility in your job. You need some FMLA. She's used that twice. But the biggest thing that she whispers to me and breaks, and when she can see me, is that, Ramona, I cannot find a psychological that Peach Care, I think that's what it's called, because she's able to get that, will pay. And so he hasn't been to school in 2 months because he will not go. It's some anxiety stuff going on. She was looking for a good doctor. She lives in Tucker. And it just breaks my heart that we're in 2015 and a parent is still in this same struggle trying to figure this out. So I whisper back because of the stigma. She doesn't want anyone to know, well, try this. Well, when I go to my meeting with Georgia Parent Support Network, I'll ask the other parents, what have they tried? But she said it was $1,500 for her to have a psychological done, which she and her husband cannot afford. So she leaves her job, sneaks, and go get her son. But she said she's probably going to have to take FMLA again with no pay. So this state worker is going to probably lose her job. She's going to change. She said she'll do whatever she have to do because she doesn't want an outcome that her son would not be educated or that her son would end up like my son, where I was working so hard that I did not stop and quit my job and give him everything that he needed.
Mm.
And that's all I have to share. And thank you for listening.
Thank you for sharing. I appreciate it. So you've given us some great guidelines on some gaps that you have personally experienced, some good advice. To come back to you, Ms. Smith, are there some other gaps that you're aware of that we should include in this conversation?
You know, I gave a lot of thought about what to say, and you're going to hear it all. You've got the best people. You're listening to all the best people. We're behind me and advising you. There are huge gaps. And I was listening to Dr. McGivney in the first meeting. Amazing man, friend, mentor, inspiration. And then I go to the schools in Southwest Atlanta where I live and work mostly. And the great things we talk about do not always get to most of the people I know in the schools. I worry if we look at the numbers. If we look at the numbers, we have a lot of really great stuff happening in Georgia. We really do. This is a time of opportunity. However, the numbers we serve, if you look at them using federal estimates of the number of people in need, we're only touching the tip of the iceberg most days. And I think, see, where I sit, I only see the things that don't work. The people that call me are people that have things that are not working. So, but I see an awful lot, particularly transition age youth, when the service ends, at whatever age it ends, depending on what system they're in, and the psychotic break happens in the next month or year, they've always been ill, they've always needed services, and then they get actually much sicker. I've had 4 of those in the last year. And they don't know about medicine, and they're not willing to listen. And I see them homeless, and I see them hurting. And I'm not even sure what the answer is. What would be the perfect answer? The perfect answer would be that they would understand medication and comply, but they don't. So our transition age youth, particularly those who get sicker, which are not the majority, but they are certainly a significant number, are one of my huge worries. The younger children who are exposed to all of the violence in our streets. Our office is across from an elementary school, and the little children are scared to walk with their parents. The violence is just amazing, and I think it's having an impact on our children, significant impact and stress and post-traumatic stress disorder on young children. Just what they see on the streets in the schools and certainly in their homes. So, I mean, nothing new. Nothing new. I see it in greater numbers than we've seen it before. The numbers seem to be significantly higher. Our calls are significantly higher. So I guess if I could wish for anything, I would wish that all the people who are going to tell you about all the wonderful programs, and they are, that we could afford to have them everywhere, or replicated everywhere, or have them available for all of our children. When we started our organization, if I'd known then what I know now, we were like a year and a half or 2 years old, and somebody said, well, we're not going to worry about, and the term, it was a state person, the term was those throwaway kids. They're already lost. They're already gone. We're going to focus on the young kids. And I never hear throwaway anymore, but every now and then I hear we're going to get the younger ones, we can help them. And we continue to not focus on our children who are older, or focus as much. We certainly are focusing on them to some extent, but it seems that they reach a certain age and we go, no, let's help the little kids. And we're going to have to help the big kids some way, somehow. Not that we don't help the little kids too, but I just think you guys have an amazingly large task, and I thank you all for being there and for listening, because, you know, I guess most of this you already know, but I think there's a great bonus to bringing people together and putting it in one place.
And we thank you, but don't get up yet because you've got a question, okay?
Okay.
Representative Gardner.
Well, I was trying to listen both to Ramona and to you, Smith, and Sue, excuse me. What we need to do is to help find both coordination and dollars to pay for the kinds of services that you know are needed. And I was interested in the child who aged out of the Medicaid program, I guess, at 18 or 21, whatever. Was that child on Medicaid?
That child got so frustrated he was not eligible for SSI, Medicaid, food stamps. He was a college student. He was not eligible for anything. Obama, because he didn't make enough, the affordable health plan. So he didn't meet that criteria. So he got no.
In Georgia.
Everywhere he went. And so he took his student loan money and he said, I'm done.
The other thing that I heard was something about the coordination of services. Sometimes when we look at where the money's spent, we're not sure whether it's more money that's needed or better case management that's needed. Certainly, I heard you say the diagnosis, getting an accurate diagnosis at the beginning, requires the most qualified professional, I would think, to determine what's really going on. And then is there somebody there to take what you've learned about that individual and create the wraparound services that I guess used to exist in our state?
In DeKalb County, there are a lot of providers, and I don't know how to word this, but they're called IFE or core service providers that replace the real wraparound. And so as a result, from what I hear from the parents and the community, that they're not pleased with those services because they're so fragmented that they get someone in college who's trying to get their license, so they'll be there for 2 months and then they're gone, and they may show up and they may not show up. So parents typically and youth, especially young, like Sue was referring to, the young adolescents, they don't even want to talk in the first place. So now you send a 25-year-old female with a miniskirt on to say, I'm your therapist. It's just not working. I mean, unfortunately, that is what we have, and that's what I hear. Now, I had not had that experience because I was a strong advocate. I would interview them before they came to my house and make sure it was a male and, all of those things. But it took, a lot of mentorship and education for me to interview them before they took my Medicaid number when my boy did receive Medicaid. But every parent doesn't know that, so they get what they get. And then it's a failure, or then they don't cooperate, and we go on, back and forth. I don't know if that answers your question, but that's what I hear from the community. They go to a psychiatrist, they book 12 people at the same time because they have trying to get the most bang for their buck, and they sit for 12 hours. So you have a parent that has a child running around in the parking lot waiting to get his meds evaluated, and this parent who has the 9-year-old, she told me if she goes through that one more time, she's going to die because she has to keep him calm while he's waiting. And she's drawing, she's coloring, she's giving him, and then he spends 10 minutes with the psychiatrist who changes the meds again.
And imagine what it's like in a rural area. I mean, maybe they're lucky and have telepsychiatry or telemental health or something, but
They have nothing out there.
It's simply not available.
Thank y'all. We could sit here and talk all day. We could. We could.
I could ask questions all day.
We could. So, and there we may reach back out to you to get some more information, but I just thank you for the work and the commitment that you have. And thank you for sharing your story about your family and particularly about Curtis. Thank you. Great. I tell you what, can you slip around here? Let's make sure we go ahead and get them. We could accidentally get out of here and not have them. So thank you so much. While we're getting those, our next speaker is Marcy Alter, the Assistant Chief Medicaid Officer for the Department of Community Health. And Marcy, you're welcome to come up here and sit, or if you need to be there for that, whichever. Just
What's your preference, Madam Chair?
It really, honestly, it's whichever works for you.
Okay. I might try here so I can
Okay.
advance my slides.
Okay,
If you
that'd be
find
great.
you're not watching the slides and just watching me, I can move.
That'd be great. Thank you. Tell us a little bit about yourself, too, to begin.
Sure.
Please.
Good morning. First, let me thank you, Madam Chair, and members of the committee for inviting us to present this morning. We, too, believe it's a very important issue and are pleased to be able to describe the services that we afford in the Medicaid state plan for children with mental illness, as well as some initiatives that we've been involved in. I've been with the department for a little over 5 years. My work in disabilities began with the Georgia Council on Developmental Disabilities, and I began my work with the state with 8 years of working in advocacy for developmental disabilities, and then have just continued to be involved and expand what is a personal passion as well as a professional interest of mine to continue that in this role. I realize I'm not presenting. Give me just a second. Okay. As I'm sure you're aware, our mission at the Department of Community Health is to provide access to affordable quality health care through effective planning, purchasing, and oversight. Today, I'd like to review at a very high level with you a review of the state behavioral health services we have available to children, as well as other services that are available to children, along with some special initiatives that we've been involved in. I also understand in a previous committee meeting that you all had some questions about EPSDT, early periodic screening, diagnosis, or diagnostic and treatment, and so I have an overview about that for you as well. And then also some very high-level select data related to utilization. First, I'd like to begin with a list, an overview of all of the services that are available in the Medicaid state plan that are available to children. It includes our psychology program, of course, access to physician services and psychiatrists through that benefit, licensed clinical social workers are enrolled and can provide services to children. We also have our inpatient facilities for children with severe emotional disturbance through our psychiatric residential treatment facilities. And then our children's intervention services and children's intervention school services offer a counseling benefit. However, in addition to those, the most robust package and benefit that we have for children's mental health services is through our community behavioral health rehabilitation services package. It really is the primary vehicle for access to mental health services for both children and adults. This next slide just lists the really robust set of services that we offer, from initial diagnosis and evaluation and development of a mental health treatment plan to individual therapy, family therapy, group therapy. And I've specifically bolded 2 of the services: intensive family intervention, which you heard Ms. DeShiel call IFI, and community support services. Intensive family intervention is modeled after an adult fidelity model called ACT, Assertive Community Treatment. That is a very intensive interdisciplinary team that wraps around an individual to really provide high-touch support to the individual. There is no fidelity model for children, but it was the state's iteration of that to try to replicate what was being done for adults in the children's sector. We also offer community support services, which really Representative Gardner gets at that case management piece that you were looking at. Our children's intervention services are two-pronged. There are the services that are provided outside the school environment, and of course the children's intervention school services, which are provided by local education agencies. So schools themselves enroll in Medicaid to provide these services in the school setting. The services include speech therapy, occupational therapy, physical therapy, auditory services, nutrition services, nursing services, and counseling services, which are provided by a licensed clinical social worker. Wanted to mention, we touched on this just a little bit at the beginning, but we also offer other exclusive children's services, which include psychology services, dental services, and optometry or vision services. In addition to the actual services that we enroll providers and reimburse for, I wanted to talk to you a little bit about the department's involvement in some other mental health initiatives. We typically partner with the Department of Behavioral Health and Developmental Disabilities, who is our operating agency for those community behavioral health rehabilitation services, on many of these federal and state-initiated projects. The first one I wanted to mention is CBAY, or Community-Based Alternatives for Youth. This was a 5-year pilot demonstration that was intended to demonstrate that community-based services could be provided for children with serious emotional disturbance who would otherwise be in a psychiatric residential treatment facility. So if you're familiar with our home and community-based service waiver programs, those under the Social Security Act allow for an entitlement to an institutional placement to be waived in favor of getting those services in the community instead of in an institution. A psychiatric residential treatment facility, or PRTF, is not one of those institutions recognized in the Social Security Act. So this demonstration was intended to demonstrate that they could be successful with the intent that a proposal would be made in Congress to make a change to the act that would allow us to create waivers specifically for children with mental health issues who met this PRTF level of care. It was a successful project. We served a lot of kids. Let me talk just a minute before I get ahead of myself and tell you that the core piece of CBAY was this intensive customized care coordination through a care management entity. And the care management entity is really the body of an organization that pulls together a combination of non-traditional Medicaid services that really help us accomplish that high-fidelity wraparound approach that Ms. Smith was talking about. That includes access to behavioral assistance, which would be both for the child and for the parent, so to help the parent learn skills to help them manage their child in the home and the community, to maintain the family structure and not have to resort to out-of-home placements. Clinical consultative services. Traditionally under Medicaid, we haven't paid for doc-to-doc consultation, but we felt it was necessary and helped with the integration of care between the a primary care doc and any specialists who are serving the children. Respite for the families, supported employment, and particularly I wanted to call out the work around family and youth peer support. This is certainly one of the national best practice trends in serving children with mental health issues, is really empowering the parents to understand and know how to navigate the system and learn from those with lived experience who have gone down that path before them. And the department has embraced that. We've partnered with the Department of Behavioral Health in that, we continue to provide C-based services even though the demonstration has ended. It ended in October 2012. I mentioned before that Congress did not pass, I mentioned that Congress was going to need to pass a bill in order to recognize PRTFs as an institution that could be waived. That bill was dropped over 2 years ago and languished and did not get passed. So the only alternative as a state agency was to find different funding mechanisms to continue it. We did, through currently, and since the CBAY project began, served 813 youth. The investment in it has been over $30 million. The majority of those have been in federal grant funds during the 5 years of the demonstration. Under Money Follows the Person in the Balancing Incentive Program, we have been able to afford ongoing access to this service. I can go into more detail about that, but I don't want to get off track. I lost my place. There was something else I was going to mention, but I forget what it is, so I'm going to move on. The Chipra Grant is another grant that was that we partnered with the Department of Behavioral Health and Developmental Disabilities, and it was a 3-state collaborative with Maryland and Wyoming, all around increasing access to care management entity work. And it's currently finalizing its 5th year. Our goal was to expand access to those care management entities and those high-fidelity wraparound services. And we, as you know, moved a significant number of the children who have high behavioral health needs from our fee-for-service population into managed care in March of 2014 through our Georgia Families 360 program. And AmeriGroup is the contractor for that. And just this year, just a couple of months ago, AmeriGroup contracted with the care management entities to provide this service. So we're really excited about that expansion and a partial successful achievement of that goal. Okay. I'm going to move on to EPSDT, Early Periodic Screening and Diagnostic and Treatment. The intent of the EPSDT benefit is to assure that all Medicaid-eligible individuals under age 21 have access to services, know that they are, our intent is to assure that they know that they're available and that they're aware of the need for age-appropriate immunizations. We do that largely through education through our primary care providers and pediatricians, whose responsibility it is to follow a periodicity schedule for conducting those developmental screenings to make sure that a child remains on course for their developmental growth. Our responsibility under EPSDT is to provide and arrange for the provision of those screenings for all children and arrange either directly or indirectly for corrective treatment as it is determined or needed through those health screenings. EPSDT, the early is making sure that we are assessing and identifying problems early, that we do it regularly during that developmental growth, that we're screening for a broad array of needs, that where needs are identified, we are referring for further diagnostic evaluation, and then as a result of those diagnostic evaluations that we're providing the necessary treatment. Of course, one of the cornerstones of Medicaid is that what we reimburse and pay for is for medically necessary services. And we define that generally as treatment that's required to correct or ameliorate a condition that exists. We look at those under EPSDT on a case-by-case basis. It's very individualized. We utilize the medical services of our medical management contractor, which currently is Alliant Georgia Medical Care Foundation. And just to mention that if for some reason a service is denied, the member and the requesting provider do have appeal and hearing rights related to that. But overall, the general intent is to make sure that the EPSDT benefit supports children with special health care needs by ensuring that they receive the individualized health care when they need it and providing those services that are deemed medically necessary. EPSDT is authorized in Section 1905R of the Social Security Act. It specifically names benefit access to screening services, diagnostic services, vision services, dental services, hearing services, and then all other necessary healthcare services, which is a great big catch-all for pretty much anything else that a child might need to stay on target with those developmental milestones as they best can based on their current situation or condition. Wanted to move on to a little bit of data. We currently have just under 1.5 million children enrolled in receiving Medicaid reimbursed services. 133,359 are in fee-for-service, and almost 1.2 million are covered through our care management organizations. The data at the bottom of the screen is for fee-for-service FY15 expenditures only. In our behavioral health program, that's the Community Behavioral Health Rehabilitation Services Program, we had almost 69,000 children participating in care with almost $42.5 million in expenditures. In our CBAY program in FY15, we served 88 children for $223,970. And there were almost 11,000 children who also accessed services from a psychologist for a little bit over $4 million. Have some children's intervention services data for you as well, both on the CIS and the school-based side. Just for your information, I included all of the other services, but specifically counseling would be immediately responsive to a ADHD or mental illness condition, and we see that those are provided in children's intervention services in FY15 to the amount of $25,297, not a huge amount through that benefit. You see that most of it is spent on speech therapy and occupational therapy and physical therapy. It's a very high-level slide on pharmacy data. We looked at the drug utilization for typical and atypical prescriptions for medications for behavioral health. For ages 0 to 3, there were no behavioral health drug utilization observed. In the age range of 4 to 12, we did the way we pulled the data was we pulled the top 20 drugs that were utilized through the program. And of the top 20, in the age range of 4 to 12, 7 of those 20 were for behavioral health conditions. and they were mostly for ADHD. And in the 13 to 18 age range, 10 of those 20 were for behavioral health conditions. And you begin to see the movement in that age range from ADHD to other more diagnosable and responsive prescriptions, including antidepressants and antipsychotics. And we went ahead and included ages 19 to 21, and 7 of the top 20 of those were behavioral health related. And just kind of across the board in antidepressants, antipsychotics, off-label prescriptions, those types of things. It's for a little bit, I forgot to add it up, but what is that, $24 million. And that's all I have. I'd be happy to take any questions.
Thank you. That's great information for us to have. You've compiled that very well for us. Are there any questions from the committee members? Representative Jaspers.
Okay, so Ms. Dempsey let me on this study committee, even though I'm not very knowledgeable about a lot of this stuff, and because I'm learning. So, Ms. Alter, Ms. Smith was here describing gaps in care, especially in mental health. And so looking at this, it kind of helped me understand, what are y'all doing to help meet those unfulfilled needs? I mean, looking at these, a lot of these weren't mental health services here in this. Some were, but what are y'all doing? I mean, I'm curious as a policymaker what you guys are doing to meet needs that organization sees across the state, not just in the metro area.
Yeah. Well, my intent in sharing some of the information around CBAY, the Community-Based Alternatives for Youth, and the access and expansion to care management entities was certainly an intent to tell you a little bit about what we're doing with that, to the extent that we have the authorization under the Medicaid Act to do it. We also are currently working with DBHDD for a state plan amendment, so that long list of services that that you saw, we are working with them to make some modifications to them and to submit an amendment to CMS that will add intensive customized care coordination, that very high intensive, high fidelity wraparound case management service to the state plan. It currently doesn't exist right now. It's only reimbursed through that CBAY program, which is funded right now through Money Follows the Person and through our balancing incentive program. So grants are really helping us fund that. We are certainly always open to recommendations. We are participating in a Georgia Coalition on Children's Health, and certainly want to do everything that we can to make sure that we continue to enhance access to services. We're always working with our care management organizations to make sure that geo-access standards are adhered to, and or that we're knowledgeable when they are not, so that they're adequate providers and coverage. Sometimes that's beyond our control. In the very rural areas, there are just no providers. But we're working a lot on new telemedicine and telehealth initiatives to try to increase access to services, and in fact have a couple of pilots going on in that regard, including a school-based mental health telemedicine initiative.
Okay. Thank you. Thank you, Madam Chairman.
Absolutely. Representative Gardner.
So it's always impressive to hear the breadth of the kinds of services that you are authorized to provide and maybe required to provide. One of the things that I was curious about is the EPSDT. Is that a may or a shall?
It's a shall.
It's a what?
It's a shall. Sorry.
Well, in your summary here, you said they may provide them, and I hear a lot of recommendations that that's something that could be beefed up. Does some of the diagnosis come through the community health programs? Not the community health, but the primary care.
It actually is all based on an outgrowth of what happens in a primary care setting. The way that it's supposed to work, the way that it was designed, is that a child goes in to see their pediatrician during a regularly scheduled well visit, and based on their age, that periodicity schedule that I mentioned, the doc says you're fully on target according to your developmental milestones, or you're not, and I'm going to either conduct a screening myself, or I'm going to refer you to someone based on how the child is presenting. So, does
it fall apart because the services are not there, or? I mean, so getting a diagnosis is sometimes really helpful, but then you've got to find somebody who can provide appropriate treatment for that particular diagnosis, and so the telehealth is helping.
Yeah, I think that we still have some improvements that we can make in really enhancing the links between the primary care physician and access to the actual treatment that happens as a result of all of those things, as well as ensuring that all of our enrolled providers are very familiar with the EPSDT benefit.
I'm just looking for the EPSDT page.
Okay.
Because I
think when
saw that it said it allows for EPSDT, and that was sort of a surprise to me. But I can't find it now. Oh, it says pretty clear here they're mandated to use. And I guess we'd have to look. I mean, my concern is whether we're meeting the need and how we can assess what the needs are. And we can talk about waiting lists, but those are already people who have identified developmental or other kinds of issues.
Yeah, there wouldn't be any waiting lists related to EPSDT. There are waiting lists for optional community-based programs for.
So there was no waiting list for the diagnosis, but then if there are treatments recommended, where do they go?
That's probably where we can help with those linkages a little bit better. That if treatment is recommended, usually the person who's recommending it is the one who's going to provide it if it didn't happen through a referral. We do have a process whereby if it is not a covered service under the Medicaid state plan, the provider, and I'll caveat that a knowledgeable provider would know that they can request that through the state, through our medical management contractor, who will do a medical necessity review determination to say, yes, this is a necessary treatment or intervention that's required for this child to attain their developmental milestones, and we will pay for it. We've done that for children with serious emotional eating disorders that we didn't have the capacity in state to serve that child, and we've sent them out of state to do that. We've done it for diapers. Diapers aren't covered as a durable medical equipment benefit, and we override that policy all day, every day for children who, over the age of 4, need diapers.
Thank you.
Sure.
Representative Jaspers.
Thanks. We look at data like this year, it's all kind of bunched together. Do you have it by age? I kind of wondered about this, and by, which kids are in defects, oversight or Department of Juvenile Justice, and can we get that broken? Is that
Sure,
that sort of thing available? Because I know it's kind of. I'm just curious.
Yeah, today my intent was to do a broad overview, knowing that once you kind of heard this presentation that you are going to probably request some breakdown.
Questions, sure.
We can slice it and dice it pretty much any way that you want. You just let us know,
Okay.
and we can make that available to you.
Well, thank you.
I think maybe part of the follow-up report might include the money, how much money goes for the various programs, and where you, in your knowledge of what's going on out there, where are the greatest needs to help us figure out what what could really happen. And the thing I was looking for earlier is on page 13 where it says the EPSDT benefit allows for. And earlier I thought you said it was mandated, so that was confused.
I think allows, yeah. Semantics.
Okay.
I think it's
I used to be linguistic, yeah.
Sorry, I'm not a lawyer. I probably should have said
That's fine.
EPSDT mandates or authorizes access to.
And the last question I hear from providers a lot about, they wish the services would be bundled so they didn't have to, and that's basically the fee-for-service versus the bundled service contract.
It's a long story. I'll try to make short. Back in 2006, 2007, CMS came in and did an audit and found that our TRIS program, Therapeutic Residential Inpatient or Intensive Services, I can't remember exactly what TRIS stands for, came in and found that we were bundling the payment that included room and board with the therapies, and they required us to unbundle it. So they made us rewrite our state plan for our community behavioral health rehabilitation services and make every single service discretely billable at the lowest common procedure code.
So that's a federal barrier to.
It is. We're starting to see under this administration some receptiveness to go back to rebundling, particularly as a result. I don't know if you've heard of the National Correct Coding Initiative, NCCI, but it encourages billing at the higher codes. So, for example, if a member goes into a community service, community mental health center, and sees both a physician and a nurse, right now, under our plan, you have to bill the physician service separately from the nurse service, even though there's another code that you could bill that would say that you did both. NCCI says you can't do that. We're not going to reimburse you because you need to use the bundled code. But under our state plan contract with CMS right now, we have to bill the two separate codes.
Yeah, thank you. If I can just make one comment, Representative Jaspers, the issue of getting treatment for kids is not an urban problem, a rural problem. It is a Georgia problem because I represent Atlanta, and getting services for kids in Atlanta is a real challenge. So we can share this one.
Thank you so much. We do share it. Thank you.
You're welcome. Thank you.
Highlighting the information. As you said, I'm sure there's going to be conversation to get some more specific data for us as well to include.
We're happy to provide that. Thank you.
Thank you. Thank you. Okay, we have 3 more sort of quick overviews coming up right now. If we could start with Early Rockette, the Regional Vice President and Executive Director for AmeriGroup. And y'all, I know we could ask a lot of questions. I'm going to let the group know as well that we are scheduled to take a tour this afternoon as well. So if we don't get to everything today, we'll pull some more in for the next one or have contact information to follow up with. Thank you.
Thank you, Madam President, for allowing us the opportunity to speak about the services that we provide to the children here in Georgia related to mental health. My name is Early Rockette. I am a clinician by training, a nurse practitioner of women's and children's health care. Worked in perinatal, neonatal nursing for over 25 years, providing care, direct care as a neonatal nurse, as well as providing as a nurse practitioner to women and children in the community setting. I have for 25, 30 years now been an advocate for equality in the health care as it relates to children and women and children, and that's my drive and my focus as it relates to the programs and working with the organizations that I work with. I will give a very brief high-level overview of the programs that we have available as it relates to children's mental health under AmeriGroup, one of the 3 care management organizations who are engaged with DCH to execute on the vision of provision of care to the members in the state of Georgia who are in the Medicaid program. Just a little bit about AmeriGroup. We have over 336 associates here in Georgia, located at 4 locations. We serve all 159 counties and 6 regions within the state. Our membership is a little over 370,000+ members, with over 80% of those children being under the age of 18, with an average age of 12. We both serve all of the TANF, CHIP, as well as the P4HB, Planning for Healthy Babies, and as Marcy indicated, the Georgia Families 360 program, which is the foster care program. Just high level, as members enter the Medicare and Medicaid programs, many of them, of course, are much sicker than the average population and have more disabilities than the average population. There's a significant amount of pent-up demand when they come into care for services. And as this graph kind of illustrates, one of the things between the difference between the commercial insurers and those members who are coming into for health insurance coverage as it relates to physical health as well as behavioral health. One of the key points in this particular graph is that it really averages around about 25-30% with behavioral health services and physical health services leading the way. For the Georgia Families 360 program, I just want to say that flips. That behavioral health services becomes a much higher demand for those children who are in foster care. It's actually between 70 and 80%, and we have to provide those services. Just to get into some of the programs that we have that are related to behavioral health and meeting the behavioral health needs of the members in our programs, we have some high-level intensive behavioral health work groups and integration programs within our organization that actually work to make sure that quality of care and access to care is available to all of our members, whether they're in either one of the 4 programs, TANF, CHIP, P4HB, or the Georgia Families 360 program. We work very closely with multiple organizations to integrate integrate our behavioral health and physical health programs to make sure that there's not that gap between a primary care provider seeing the member and the behavioral health provider. One of the ways that we do that is we actually have in our system a way for when our contracted providers go in and look into our system, they're able to see a bit of the medical care background as it relates to those members, both the physical health as well as the behavioral health. And we really think that's going to be key for providers because there is that gap, or has been that gap, between the knowledge of what's been going on in behavioral health and what goes on with physical health. So we want to try to mitigate and close that gap. We have a psychotropic medication program where we actually look at children who come in and are on psychotropic medications, one or more psychotropic medications. We look at that. We assess what the medications are for. We bump it up against diagnosis. And we also send out information, or alerts is what we call them, to those prescribers and indicate to them, little Johnny is on 3 or more psychiatric medications, or little Johnny is on a medication that's in the same class as another medication. There's duplication. We need you to take a look at this. Or there are multiple prescribers for this particular medication, which can sometimes lead to over-medicating our children. So we have this program to try to take a look at that and try to help mitigate some of those issues that are related to psychotropic medications and their use in the population. Of course, we want to improve the outcomes, and that's the primary goal of this program, and we feel very strongly that we are getting to the bottom of some of the issues and unearthing some issues that we know that we need to continue to work on. As a part of our efforts to manage the behavioral health as well as the physical health needs of the members, we have our complex case management and care coordination for all children, not only the children with behavioral health. We have our teams there trained and are being trained, high fidelity wraparound. Sue actually came and spoke with us very early on in our program, and she still has that same passion and energy related to that program, which we're very happy to be a part of. We also contract with Sue and her team to help provide peer and family support, which we think is very important in maintaining that family structure and trying to help the children as they transition through these very stressful and intense healthcare systems. We have, of course, as Marcy indicated, the IFE and CSI services available to the children. We audit those programs to try to ensure that those gaps that I think have been mentioned previously, that we're trying to address those gaps if identified and correct them as we need to. We have expanded our expanded behavioral health network, which includes the licensed professional counselors, licensed clinical social workers, psychologists. We also have the psychiatrists and multiple other behavioral health providers, but we go beyond the general benefit by having these other associate and affiliate mid-level providers who can help service our children. As a part of our GF360 program, or foster care program, we received a $5.8 million CMS grant, and that grant is for a program called Coaches. And as Sue indicated, there's a gap between transition age youth and what they know as it relates to being able to function once they transition out of the healthcare system. This particular program is geared toward coaching those individuals that have behavioral health problems and helping them to be able to be functional and make decisions and related to housing and finance and all of those things that we teach our children about. This program is geared toward that. We partner with Families First. We started last September. As of right now, we have over 100 children across mostly metro counties and hopefully expanding in the next year to some additional counties outside of the metro area, but we have over 120 youth that we are serving currently in this particular program, and they have coaches assigned to them that are very intense with working through with them and making sure that they're able to function and maintain once they've transitioned out of care. AmeriGroup, the Provider 360 is the member profile that I mentioned earlier that has the providers have access to when they come into our system, which provides information not only on physical health but behavioral health information related to what has happened with a member in our system. We also partner with the telehealth community, work with DCH as it relates to providing telehealth in the schools, and the behavioral health is our biggest utilizers of this particular service. They utilize the service a lot in the rural areas because we know that that's a gap, kind of a desert sometimes, not because we don't want to provide services there, but they're not providers there who can render those services, so we bring the service to those members by using the telehealth methodology. We have created some creative community collaborations and partnerships. Marcy mentioned the care management entities, which we have contracted with, and we are actually have members assigned to them. They work with us to provide intensive high-fidelity wraparound, as well as our internal teams have also worked and have developed these skills as well. Again, they provide family and peer support and helping to empower those families to make those decisions and try to keep those children in the communities. And again, that's our care coordination team also supports that same philosophy and principle. We have a program that we have partnered with and developed with Chris Kids, Youth Villages, and MAC. That program is, again, geared toward children who have behavioral health issues, and they work with the children to, again, provide them with the services that they need, help facilitate them transitioning home. Youth Villages actually follow the children for a year after they've been discharged from either our foster care program, but they still have Medicaid, at least with AmeriGroup. They follow those families for 1 year, and we think that service will be significantly impact the outcomes as it relates to children, especially children with mental health conditions that are being returned to the home. I've indicated our peer and family support work. We also work very closely with Ron Skaggy, Kate Cantrell, and the Together Georgia group. We have meetings. We started out about a year and a half ago, having very intense meetings about the requirements as it related to the provision of behavioral health services to members. We have a very collaborative relationship. They help and make recommendations to us as it relates to behavioral health health services, and we work very closely with them. So I'm very happy with that relationship and the development of that relationship with that particular group. Just at a high level, again, we were kind of asked to present at a high level. Wanted to share some information with the total membership and our GF360, which again is the foster care population. Just looking at outpatient behavioral health services, over 36,000 members received services from quarter 22 of 2014 through quarter 3 of 2015, accounting to about $53 million worth of services. And inpatient behavioral health, which includes some PRTFs, the inpatient mental health facilities, hospitals, over $30 million for 2,200 plus members that are in our Enroll with Amerigroup. In addition to our services, specific and innovative programs related to behavioral health, we of course provide our primary care services and care coordination related to those services. Every member has a primary care physician, and in our Georgia Families 360 program, they also have a primary care dentist and access to behavioral health services. We are one of the organizations we're working with behavioral health specialty practice to be the first NCQA recognized specialty practice in the nation, and that's tentative for November of 2015, and that is with Georgia Hope. We have a behavioral health crisis line, a 24/7 behavioral health crisis line. We work on process improvement initiatives related to ADHD and antidepressant medications, as well as looking at clinical practice guidelines around specific behavioral health problems. We do this through the work of a system of care and multidisciplinary teams. We have multiple, not only providers, but entities that we engage with to try to make sure that our members are receiving the services that they need, whether that be behavioral health or physical health. We want to make sure that it's inclusive and that we've covered the services and try to identify and address any gaps, and that there's minimal conflict in the care plans that are being developed by multiple agencies that engage with our members. Any questions?
Are there any questions? And I will tell you that I know we are going to ask you to come back at another time as well. After I think you're going to get this information perhaps to Roma, and then she'll send us so we can kind of study it a little bit more and come back.
Absolutely.
Just a quick question. When you come back, I have a PRTF in my district, Hillside Cottages, which is right in the middle of Atlanta, and they report to me that they have had fewer referrals and that the length of stay has reduced significantly. I'd like to know a little bit more about that. Maybe we can talk offline.
Absolutely. Absolutely.
Thank you so much. That is some great information, and I feel sure we will have some strong questions to come back with. Thank you. Okay, next up we have Jeff Luce, the Clinical Director for Behavioral Health for Peach State. Welcome. Tell us briefly about yourself, please.
Thank you.
Too.
Yes, and thanks for having me. Let me get my slides up here. There we go. Yes, my name is Jeff Luce. I'm with Peach State. I'm the Clinical Director for Behavioral Health. I come to managed care in Peach State via the provider, outpatient provider community here in the Atlanta area. So all of my clinical background and experience has been serving high-need kids, particularly adolescents, with significant behavioral health, mental health challenges. I've also done some healthcare and child welfare consulting prior to coming to Peach State, and I've been there a year as clinical director over behavioral health. So just by way of high-level overview about Peach State, obviously we're one of the 3 care management organizations since go live in 2006. We've got 128 hospitals and related facilities statewide, 19,000 physicians and other types of providers and network nearly 1,600 behavioral health focused specialty providers, and approximately 8% of our populations, around 26,000, have primary mental health issues. And of those, about 60% are ADHD or similar diagnoses. With our behavioral health program and services, we work to ensure that our members are getting the right service at the right time. In an average month in 2015, nearly 10,000 members were accessing behavioral health services per month. We really believe that one of our primary objectives and responsibilities is to figure out how we can intervene early with mental health. We aim to deploy a prevention mindset for members whose immediate presenting problem may snowball and grow if left unaddressed. We're asking questions internally like, who are the young kids today who will be our high-need, high-end 13-year-olds a few years from now? What can we intervene with now? What opportunities can we take now? And we're really asking those. We're constantly really refining and working on how we can better identify these kids. Things like identifying multiple psychotropic medication in young kids, escalating behavioral health need, increased physical health needs that may have underlying behavioral health conditions. Part of our refinement process has to do with the ways that we bring together traditionally disconnected clinician types. And we're supporting and pushing our behavioral health provider network to look at and intervene with a whole health picture in mind. For example, bringing PCPs under a behavioral health provider to provide and to monitor physical health services. And our internal work at the health plan mirrors that effort. We have our entire medical staff is fully integrated with our behavioral health staff. We're constantly staffing cases, looking at the whole health picture. So obviously at a granular level, all of our workflows, processes, systems, et cetera, support our desire to be fully integrated. Our network is truly a continuum of care, from psychiatrists to therapists to community support individuals, all the way across the spectrum. It runs the network runs the gamut from being able to address psychotropic and higher end needs, all the way down to we've got clinicians who are able to work with kids who have impulse control problems or maybe some oppositional behavior that is escalating. Our staff, our internal staff, are Georgia licensed mental health clinicians, social workers, professional counselors, psychologists, psychiatrists. These staff handle the utilization management, and care coordination functions at the health plan. As we look at outcomes, we're really asking if members are getting what they need and when they need it. We have measures that we monitor around ADHD medication compliance, antidepressant medication compliance, services received after someone goes inpatient for a psychiatric stay. But we also work diligently to engage with our members one by one to look at the treatment goals that they may have. We measure outcomes all the way down to this level of the members that we are able to engage with. Who of those members are able to successfully complete their treatment goals and to get what they need. When we say innovation, what we mean is that we are streamlining access and increasing quality. In that effort, it's been stated before today already, but we partner with the Georgia Telehealth Network to help increase service delivery reach, particularly to rural areas in the state. We've seen steady utilization increase in that domain over the past few years. I'm particularly passionate about school-based delivery of mental health. This is a big part of my career in Cobb County. I was a part of an agency where we were one of the first providers to be in school, kind of underground, doing this work in some high-need, high-intensity schools. My first office was a broom closet at Osborne High School. Over there. So that was some work that I've done. So I'm very passionate about that, very supportive of DVHDD's effort around that. Our case management programs, we have an ongoing and increasing emphasis, again, on early intervention, while also keeping in mind that we don't have any lost cause cases that we manage. We don't have any lost cause kids that are in our plan. So we fully identify the need all the way up to the time that they age out of our program and beyond. So with just want to share some utilization statistics. So for inpatient psychiatric utilization, since 2010, we've had a 13% increase in utilization. Obviously, that's controlling for membership growth, et cetera. So it's controlling for that factor. On the outpatient side, since 2010, it's a 130% increase. So obviously there's a why there, right? Why is that the case? We're looking at that, and right now what we're saying is it's our ability, or what we did to expand the provider network, paired with the provider community and their willingness to really meet members where they are. So a lot of in-home services, in-school services, and really just meeting members where they are. So again, we aim, our daily aim is to work toward getting our members the right and needed services at the time that they are needed. And if I may, I'd like to finish by sharing just two very brief examples of how this happens at Peach State. So we recently worked with a mom of a 6-year-old. The 6-year-old boy had some emerging behavioral health issues related to ADHD and oppositional behavior. The nuance of this case was that the mom was hearing impaired, and so she could only communicate via sign language or email. Obviously, anytime you just have an email communication with a brand new person, a lot of things can get lost in translation. You can misread intent, all of those kinds of things. And she expressed that whenever she's tried to communicate with just people in general in this way, a lot of challenges arise. Our case manager, who was working on that case, did initially have some difficulty strictly with that email approach. But we were able to cut through that because the mom's tone was clear. She needed help, and her son needed help. And she cared deeply about him. And really what she needed was help finding a provider and then coordinating what needed to be done around that. So our case manager was able to patiently help this mom navigate a sometimes challenging behavioral health system, ultimately helping her identify the right provider, making that connection, and then facilitating ongoing translation services that will be needed in order to have success on this case. And then finally, a second example, we recently had a female teenager who had been inpatient for a psychiatric stay twice in the course of 3 months for depression. Obviously, with that kind of utilization, that gets on our radar. Hey, this kid's got some significant need in her life. So we connected with that family. We identified that we really did need to ramp up our efforts in order to meet that escalated need. We engaged with the family, and ultimately one of our case managers connected with that family, met that family and that family's therapist at their house to just do a deep dive on what was going on. What were the needs? What are some potential unmet needs? Throughout that conversation, a lot of stuff came out. It was a very positive, meeting. It really was. But the thing that ended up getting focused on were the long-term goals for this teenage girl. What do you want to do? What do you want to be? So she was very interested in technology, wants to pursue a career in that. Our case manager, because we've got a really great and strong staff, our case manager had all kinds of resources kind of just at the top of her mind around what that girl could access in the school setting by way of technology and get her moving in the right direction. So it was a great meeting. They set some kind of ongoing follow-up to follow this girl. And, our focus is to continue to help her stabilize and move toward thriving. So thank you so much for having me.
Thank you so much. I think we have one question, it looks like.
Is it true that you actually contract with another corporation to provide mental health services?
So it is a complicated answer that's actually not that complicated. So my business card says Simpatico Behavioral Health. Simpatico is the behavioral health arm for Centene, which I office a couple doors down from everybody at Peach State, same floor, same systems, everything. So yes, functionally, it's not anything to...
So if Simpatico has a problem that the state needs to sue somebody, the contract is with Peach
State, correct.
And if it's not, if it's the contracted provider, are you responsible for the payment or the problem? Or
we can certainly get that question. Obviously, that goes beyond my mental health training to answer sufficiently. I'm so sorry, but we'd be happy to get you kind of the workflow and on all of that.
I just want to make sure that we're covered for anything that could go wrong.
Yes.
Thank you. I appreciate that.
Absolutely.
Thank you so much.
Yes.
And again, all of these will be emailed to the members of the committee so that you'll have this to look back on, and then we will probably have more questions. And thank you for sharing that story particularly. That was very, very good. I do see your passion. Two more speakers. So Dr. Dada Griffin, I believe, and Remy Rodriguez. And Remy Rodriguez is the Director of Behavioral Health Operations for WellCare of Georgia.
Good morning. It still is morning, isn't it?
Barely, it is.
On behalf of WellCare, we would like to say thank you for allowing us to come to join this conversation with you today and to share with you some of what we do to help take care of the behavioral health needs of the pediatric population of your constituents, our members. My name is Dr. Dauda Griffin. I'm a board-certified child and adolescent psychiatrist. I am the Behavioral Health Medical Director for WellCare of Georgia, and I have been with WellCare for approximately 4 months. Prior to joining WellCare, I was on the provider side, where I owned a multidisciplinary private practice. I have worked with a community service board, the Georgia State Prison System. I've been the medical director of a PRTF in Atlanta, and am really excited to bring all of those experiences to my role at WellCare. I will share in my presentation today with Remy Rodriguez, my esteemed colleague who is the Senior Director of Behavioral Health Operations for WellCare of Georgia. Our agenda for this morning will be to share with you who we are, to discuss healthcare quality and access, to share with you some of the innovative ways we are integrating healthcare, to discuss how we track and monitor quality, and again to discuss some innovative things that we are doing. Our vision is to be the leader in government-sponsored healthcare programs in partnership with members, providers, governments, and the communities we serve. Our mission is to enhance our members' health and quality of life, to partner with providers and governments to provide high-quality, cost-effective healthcare solutions, and to create a rewarding and enriching environment for our associates. At WellCare, we call employees associates. Our core values, there are 4 of them. They're partnership, one team, integrity, and accountability. WellCare of Georgia currently serves 653,000 members, which makes us the largest CMO in Georgia. We have 5 local office locations, and we have about 305 associates, or again, employees, throughout the state. In terms of, this is what we call a heat map. It shows you the distribution of our pediatric population with behavioral health diagnoses. The darker the color, the more intense the concentration. And so you can see there that it's mostly concentrated around the Atlanta area. A majority of our pediatric behavioral health population is Caucasian, and close second to that is Black. In terms of quality and access, so of course access plays a huge role in the quality that we are able to provide to our members. We have a little over 5,000 primary care providers, about 22,000 specialists, about 1,900 behavior health and substance abuse providers. We have 150 hospitals. That includes physical health as well as behavioral health. We're contracted with all of the community service boards, all 26 of them. We also contract with 160 of the FQHCs, 115 core providers, and 68 intensive family intervention providers. We have geographic access standards that we have to meet, which include one primary care provider within 30 minutes for an urban county or 45 minutes for a rural county, and one hospital within those same time frames. Also, in order to address some of those gaps that have been discussed throughout the conversation this morning, we too believe very strongly and have a passion for school-based care, and we have partnered with Emory University at a high school in Clayton County to provide behavioral health care. This clinic is, it partners with the school, but it is sort of standalone. It is actually connected with an FQHC, so it is not bound by the same schedule of the school, but they also provide physical health care as well as behavioral health. And we are looking at outcomes such not only related to their physical health, their behavioral health, but also those academic outcomes, which are closely tied and improve as their health improves. In those areas where it is difficult to identify a provider because they just aren't there, we have a couple of telemedicine programs in Crisp County and Appling County, and we also provide telemedicine or school-based programs through core and community service board organizations. We have a partnership with Tanner Medical Center as well as the Apex Project. And now I'd like to introduce my colleague, Remy Rodriguez.
I'm Remy Rodriguez, and I'm the Senior Director of Behavioral Health Operations for WellCare. I've been around the behavioral health world for more years than I like to admit. I actually started my career here in Georgia as part of the BHDD Systems of Care program. I have a master's in counseling psychology from Georgia State. I then moved on to Florida and Puerto Rico and have worked in their healthcare systems. I was even part of the first program in Puerto Rico where they brought universal care to all their members. I'm pleased and glad to be back in the state of Georgia. I've been working with WellCare for the last 3.5 years in our integrated behavioral health care program, which I'd like to tell you a little bit more about today. At WellCare, we look at behavioral health service with an integrated system where the member is the center of the system. As we look at the member's needs, we look at care coordination and provider engagement and have specific programs to address both. For provider engagement, we closely partner with our behavioral health network that Dr. Griffin has just gone through. We do that in a contractual manner, but we also do that by having continuous meetings to get their feedback and input. Part of that, we meet with Together Georgia, very similar to AmeriGroup, on a monthly basis. We also meet with the CSB Association on a monthly basis. And we have a physician advisory council where we have clinical input from clinical experts in the state. Our care coordination begins when the member actually comes to WellCare and they're first identified as a member. Based on their level of need, we identify the member in different care coordination programs. The first needs assessment that is done is through the health risk assessment. And as the member's needs increase, we have different case management programs that meet the need. Another philosophy of WellCare is that we like to look at the whole person. So when we do assessments, we not only assess their physical behavior, but we also look at their social needs. As we know, many of our Medicaid members have social needs that have great impact in their physical and behavioral health. Our care management programs are multidisciplinary programs. They are both telephonic and field-based based on the need of the member. The field-based programs are gathered in what we call pods, and they're interdisciplinary programs that have a pediatric nurse, a social worker, a behavioral health licensed person, a general nurse, an OB nurse, and a community care coordinator, a community health worker that helps the team identify those social issues. That our care management program is wrapped around by our advocacy program, where we partner with community safety net providers such as the United Way, Boys and Girls Club, to bring those additional benefits to our members that'll help them reduce the barriers they have to receiving behavioral and physical care. Quality is a very important part of our program, and we measure all quality services through our quality department. We look at care gaps through our HEDIS measures and how we can close those care gaps. In order to do that, we partner both with our primary care physicians to ensure that they're providing the EPSCT services that Marcy talked about, as well as preventative services, and that there is that linkage and coordination with behavioral health providers in the community. This is a map of our regional pods, our interdisciplinary care management teams that are field-based. As you can see, we have 7 of them that throughout the state, and they serve various areas in the state. And as I mentioned before, our field-based case management and pods, as we call them, have field-based coordinators, social workers, clinical social workers, OB, community health workers, care coordinators, and utilization management. One of the programs we focus on is the care coordination between the PCPs and the behavioral health providers, and ensure that that communication is bilateral communication with the appropriate consent from the member. We also encourage our psychiatric hospitals to notify both the PCP and the behavioral health providers of those admissions. We find it difficult that members that require psychiatric care to transition back into the community, particularly since many of our members need to travel long distances to get psychiatric care in a hospital, so that transition back to the community can sometimes be challenging. So we work with our hospital providers in order to be able to do that transition. Some of the HEDIS measures that we particularly focus on for children include follow-up for children that are prescribed ADHD medication. In the population that we see, the #1 outpatient diagnosis is ADHD, attention deficit disorder with hyperactivity. So we work both with our behavioral health providers and our primary care providers, who are most of the time the prescribers of ADHD medication, to ensure that they provide the appropriate follow-up for our members. One of our other focus has been that follow-up after discharge from the hospital, because of those important transitions back into the community, as well as looking at antipsychotic medication. Many of our children are on multiple antipsychotic medications, so we closely track and monitor that with our providers. As I talked about, one of the programs that we've been looking closely at is that transition back from the community. The research shows that if a member becomes engaged in their community care, there was less likelihood of readmission. So in order to focus on that, we've embedded a care manager discharge planner into our high-volume hospital, where they can actually work with hospital staff to not only do the utilization review for that member, ensure that they're receiving the appropriate care at the appropriate level, but also to assist with discharge planning, particularly in those rural communities where there may not be immediate accessibility, so they can help them look at different alternatives, such as our school-based clinics or telepsychiatry. We incentivize our hospitals through what we call the Go Car program, in that if the hospital is able to bring their HEDIS rates around discharge planning, we incentivize them with care management. We also look at innovative ways in order to reach adolescents. Our COBOLT program is one of those innovative ways. It's a computer cognitive-based program that looks at anxiety, depression, substance abuse, and insomnia. And our members can initiate this program from their computer, their handheld, and be able to go through different modules that can assist them with their cognitive thinking, their behavioral outcomes of that. And it's a way to both enhance current services if the member's in therapy, but it's also a way to reach a broader population that our primary care physicians can reach when there might not be immediate access or immediate willingness to to receive behavioral health care. Thank you so much for inviting me. Any questions?
Thank you. Y'all have given us so much to think about, and I really think a much better understanding of what the 3 CMOs can do. We will, I know each, and our 2 members that I said earlier could not be here today because of another meeting. We'll all go through this, and I'm pretty sure we'll be back to you. So thank you so much. Before we stop, I just want to tell you that I know this room has been so very quiet and respectful, but as I look in your eyes, I see that passion and your energy. So I appreciate your commitment to be here today and to help us in this conversation. I want to thank Betsy Howerton, too, back here with Legislative Council. Betsy, many of you already know her probably because of the work that you do here at the Capitol, but she is such a good listener, and it's going to certainly be helping us as we work to put together the document that will wrap up our findings here. Our next meeting, just to make all of you aware of, will be November the 9th. I don't have a time yet, but look for that notice to come out soon. I just thank each of you so very much. We've got a lot of work to do, and we are diving deep, as was stated just a little while ago. It is a little bit overwhelming, but I'm so glad that we are having this conversation. Thank you so much. I look forward to seeing each of you again soon.